So there's few terms you have to know. These are diagnostics. Okay, one of them is the bone scan. You already know what it's used for. Based on the name, it's a bone scan. So it's basically we're looking at the rest of the bone, but how is it done? They had to inject some dye. It's called technetium. So it's a radioactive substance that's injected into the vein. And then it's used to view every skeletal body system in your body. Everything, all the bones in your body can see it. You can see everything over there. It can also use for, like, if you have infection, if you have osteoporosis or osteomyelitis, yeah, you can use it. And this can also use for osteoporosis to see your bone, if there's any weakness, any bone anywhere. So it's a very, very good study, right? Everybody get a bone scan. Or if you have arthritis, like you said, infection, you can use it. Okay. The most important thing you have to remember that they can ask you is when you inject the dye, which is an isotope, you have to wait 4 to 6 hours before they can do the study, so they can get to every bone, go through your vein, and going through every system before we can do the study. And then what you have to ask the patient, not everybody can get this. You have to lay still for 30 to 60 minutes. That's a lot of time sitting there, laying down for pictures to be taken. Some people cannot take it. So, and you have to, after the procedure, post-op management, post-procedure, you need to give them fluid to wash away the dye out. So fluid, so you can encourage fluid intake. This is all you need to know about bone scan, basically. Okay, they will ask you what is it used for, what are the indication, and what did you have to teach the patient. They have to be able to lay flat, and then you have to wait 4 to 6 hours before the study. Okay. Another word, you've heard it before. These are all definitions so that when you see a question, you don't panic. Arthroscopy. Scopy means camera, looking. Arthro is usually your knee. So I'm looking or any joint. So joint basically is the right word for arthro. It's orthopedic. And then the scope is just looking with the camera. So looking with the camera. So they just look inside your joint with the camera. And then if there's any pathology, they take care of it. So you're going to have this. There's no like any big surgery, just a small, tiny incision in your knee. They put a scope in and look inside the scope, and then they're done. They can tell you if the joint is defect, there's any cartilage problem or stability of it. Okay. The contraindication. So contraindication, you can't do this. You cannot do this if there's infection, because then if you put something there, it's going to introduce infection into the joint. So you don't want that. And then the patient should be able to bend the knee, because when they go there, most of the time, to be able to see the knee is like that. This is how they do, and they're making what they call stab wound here, and they go into the knee with the camera. You can't do that when the knee is straight. So the patient should be able to bend the knee. So that's another requirement, okay, that is needed for the procedure to be done. So you have to bend the knee at least 40 degrees. So the joint, whatever, at 40 degrees. So your job is what you do after the procedure. So post-management. The highs is fine, right? And let them elevate it for 24 hours to avoid edema. That's what usually you teach the patient. This is where they can trap you. When they have this procedure, they shouldn't move the knee. Well, they should start exercise right away, physical. Otherwise, the knee will lock. So physical therapy is good. They start moving a joint mobility to improve the function of it as soon as possible. They may ask you, do they need to be MPO? Yes, sometimes they do this under general anesthesia. So if they're doing it under general anesthesia, yeah, you got to be NPO at least 6 to 8 hours. So NPO in 6 to 8 hours if doing it under general anesthesia. But most of it is done under general anesthesia. So it had to be NPO, okay? I'm just giving you quick facts. I'm not going to waste too much time. These are the things, basic things you need to know. Then there's this, there's a scan. You already know about it, okay? And what it is, if you see this, is draw 2, okay? 2 energy, X-ray. We're using 2 X-ray to allow absorption to give you a picture. That's all. That's what it means. So draw energy X-ray absorption metric. Basically, it's giving you information, and that is what the DEXA scan is. That's all. And you know, the most important thing is because it's an absorptive study, it's going to tell you about the bone mineralization density. So how is the density of the bone, the content of it, how great it is. And the number one use is the osteoporosis or osteopenia, how people with a very low bone density, basically. Everybody, when you reach 40 years old, female especially, should get a baseline. I know we don't do that, but the baseline, you need to get your bone density at the age of 40 so that you know if you're going down, because you start becoming menopausal, basically your level of estrogen start to go down and it can affect your bone mineralization. And so you want to know your density, whether you are at risk of osteoporosis or not, but people don't do that. Okay. When they're doing the study, they will ask this if they're going to ask you, okay, they have to wear loose clothing, very, very loose, no metallic. So there shouldn't be any zippers on it or metals on it, okay? Otherwise, it will affect the scan. All jewelry need to go. Piercing anywhere. You got to tell me where you have piercing that I can see, okay? You have to tell them so that they can pull. You have to pull it out before you, otherwise it will affect the scan, okay? And they need to stop their vitamin D and calcium. They need to stop it before the study, at least 48 hours. Otherwise, you are affected. You want to know your baseline, what it is, if you don't take any medication. Okay, so those are the first 3 study. You may see this. Let me see. You see this somewhere, EMG. All it means is electromagnet. So electromyography. Which is the same thing as nerve conduction study. And based on the name, it's electromyography, muscle function. We're trying to see the activity of the muscle function in addition to how is the nerve is conducting through. So you can think about it. EMG, what am I going to do? I'm going to stimulate the nerve and see what it does to your muscle and what is the muscle is doing. That's all. Okay, so people who have a muscle problem, yeah, that's what we use to see how the muscle is, whether it's weak or not. So we stimulate the muscle to check their function. And then you can think like what kind of pathology or problem as a muscle problem. You know it already. ALS. I mean, they have muscle issue because of the nerve conduction. They have myasthenia gravis. Number 1 that you should know of, right? GBS, Guillain-Barré syndrome. All of them, they have muscle issue correlated to the nerve. And then the nerve may be functioning. Some of them nerve is affected. And so conduction is affected. And so that's why they have weaknesses, every muscle in their body. This may be a trap that you say, oh no, you can't do that. You can. Remember, they're testing the muscle function. And so they're stimulating the nerve. You have to tell them whether the muscle is moving or not. So you perform some activity, some function during the study. I will let you squeeze your hand, flex your hand. I mean, move your hand certain way so that certain muscles, whatever I'm targeting, I want you to do the movement associated with that muscle and see if I can see how the muscle is contracting. So performance of activity during the study is normal. They will do that. Don't say it's going to affect the study. No, that's what we want to see. Okay. After the procedure, because of the needle, they use some needles. You got to check for hematoma. So check that area to make sure there's no bleeding. Because of that, the client will be worried. So you got to manage the anxiety. You have some anxiety about pins and needles. Some people don't like it. So that's your management, manage the anxiety so that they will be comfortable with the study. It's magnetic, right? Resonance, right? Imaging. So we getting information using a magnet, big magnet. It's a huge magnet. That they put it inside and they try to do the study. It's going to use a radio wave. So radio waves and a magnetic field. That's all. Like I told you, huge magnets to give you some imaging. It will give you any image of the body, bone, whatever, but it's good for soft tissue. Okay. Because of the magnets, guess what? No metal. Once again, you have to tell me any implanted device that is metallic. Okay. Any piercing that I can see, yeah, tell me so that we can remove it. Okay. Patient who have pacemaker, no, they have wires. We can't take the pacemaker out. It's a problem. There is if they tell you, usually you have to ask the patient, which we do. The first thing, if they tell you they have metallic object in them, doesn't mean is a contraindication. Pay attention. You have to ask if it is MRI compatible. Okay, you have to ask the patient. They may not tell you in your test. So if they say they have metallic object, you say, okay, well, you can't have it. But if they specify it's MRI compatible, or if the answer choice, there's MRI compatibility there, yeah, I want to know if it's MRI compatible. There is a cochlear implant, hearing problem that are MRI compatible. Patient they have implant in their ear and they will be able to get MRI. There's some orthopedic rods that is MRI compatible. You can get MRI with that. So it's a question you have to ask the patient and figure out if they have documentation to show that. Patients who have joint knee replacement. Sometimes nowadays they're using titanium. This is okay with MRI. If you see in the question, it's okay with MRI. Titanium implants are okay for a joint. Very, very important. If you've done this before, they put you in the dark place. Claustrophobia, yeah. You got to ask the patient, you have to ask them. If they are where they can, you got to find something. Sometimes they give them sedation to help with that. So you got to find out if they claustrophobia, because that's not fun to go into that small hole they will be there and they have to lay supine, another one, 45 to 60 minutes. You're just there for that long before throughout the study. And it's very small space, moving. You can't see anything. You can't see. It's dark, pitch dark. And so these are some of the things you have to find out from the patient. Okay. These are baseline things you have to know so that you study, you see it. There's some lab works that come with musculoskeletal. We always want to know your calcium, okay? I need to know your phosphorus, okay? We need to know your alkaline phosphate. When you see it, it means bone problem. We need to know your ESR. This indicate infection, and CRP, infection. If it's just a muscle problem, creatinine kinase, so that if they give this to you in a patient who has rhabdo, you see that it will go up. So those are basic lab work that when you see it, it's just indicating that the patient has either a bone or a muscle issue that you're dealing with. So this is the beginning, diagnostics. Okay, now let's get to business. This one, they like asking. I put them together because I want you to know the difference between them. Okay, the difference is very important. So arthritis is just inflammation, okay? Inflammation of one or more joints. It can be smaller joint or bigger, long bone, bigger joint. So you have small joints, you have big joint. All of them, most of them, they may have pain, classic. They have swelling there, okay? It may be stiff. And the range of motion will change. This is classic for any arthritis. That's what we call it. But you have to know which one it is. So the type is you can have osteoarthritis. You can have rheumatoid arthritis. You have gouty. I call it gouty arthritis. Okay. You can have septic, just infection of the joint. And there's arthritis you find in kids, they see juvenile. It's the same thing as rheumatoid, the same thing. Any other joint, but it's specifically for young kids. So these are the few ones you should know. So, okay, what is osteoarthritis? Try to compartmentalize them so because they will confuse you with each one of them. Think when you hear about osteoarthritis, consider that as like you have a car. What your car will do? You bought a car and it has a tire. What do you think? It's wear and tear. That's all. So as you age, you get older, you use the joint too long, you don't take care of it, well, it breaks down. And then you start having pain. Okay. That is what is the osteoarthritis. Basically, the joint has cartilage. So if this is the joint and the two bones, one bone is here, one bone is here. In between them, the joint, the bones don't touch each other. This cartilage wear off, and you'll be left with this little tiny joint and the bone now touching each other. And that is all what is osteoarthritis. Now you have pain when you move it. Okay? So pain when moving. Pay attention. But the pain get better at rest. That's different when we talk about rheumatoid. It's different. You can see it. So this is wear and tear, pain when you move it, and pain get better at rest. Okay, it get better. Think about it. You see the pain better. I mean, you see the effect of the joint wearing off in the bigger joint. Mostly that's where you use it most of the time. So the bigger joint, yeah, your knee joint, okay, your shoulder, those kind of bigger joints, yeah, those are long joint, large joints. That's where you have this problem, not the smaller ones. So large joints, they are getting into trouble, okay? And this is usually asymmetrical. Once again, this is key. You're usually not going to lose two of your knee, otherwise you can't walk anymore. So it's mostly one knee that, if you listen to old women, they say, or men, they say, my right knee is always, my right shoulder is killing me. Yes, it's always one side, not two sides. So it's asymmetrical, involve large joints. You get pain when you move it, but at rest, the pain is fine. So you can think of risk factors based on the pathophysiology. So risk factors is what? Where age, okay? Right? Excessive use of it is the problem. So excessive use of it will put you at risk for that, right? Unfortunately, female, I don't know, it's just bad. And obesity and smoking, these are risk factors for that. You kill all the joint and cartilage and you destroy them. And they have this problem. You have to know that is symmetrical, is asymmetrical, large joint, and when you're pain. So the treatment, you see, there's no infection, there's no inflammation, it's just the wear and tear. Therefore, NSAID is their friend, NSAIDs, and exercise. The exercise is isometric. They want to strengthen the muscle so that it can compensate. Isometric, compensate the bone defect. So you want to raise your leg up and keep it in the air and don't move your joint. That is strengthening. Isometric, to improve the muscle, to help with that. Okay, they can heise and put a heat on it. That's fine. So these are okay, but they need to take adequate rest. Otherwise, you get worse. Sometimes they ingest steroids, so but most people NSAID are fine. Okay, there's a question. Let's see. Okay, so I gotta take this off. Okay, there's no question. Any question so far? So this is what you need to know about osteoarthritis. Signs and symptoms. For the next generation, this is the way they will present you. Chronic joint pain. Okay, they will tell you they have stiffness. The pain is relieved at rest. Once again, I'm trying to emphasize so that you can resolve at rest. But where's with movement? The muscle will be atrophic. That means the muscle will get smaller. That's why you need to do isometric exercise to improve it. The joint is going to swell. Those are all things you need to know about osteoarthritis. How do you diagnose it? They get an X-ray, it's fine. They can get an MRI. Anything that will look at the bone is okay. You can get an ESR and CRP, but don't expect this to be elevated. This is how you can distinguish between this and rheumatoid. It's not. It may be slightly elevated, but not. So don't pay attention to that. And that is everything you need to know about osteoarthritis. Okay. His friend is rheumatoid. This is an autoimmune. That means your body is making something to cause it. Autoimmune disease, causing the inflammation. So you know that just taking Motrin is not going to help with that. So there's some antibodies causing the problem, and that is making you get your joint affected. Key facts: these are small joints, not the big one, and they are bilateral, both sides. So anybody who have rheumatoid arthritis will tell you, oh, my two fingers are hurting. They look the same, symmetrical. So usually the hands and feet, yeah, those are the ones that get into trouble. Their stiffness is very important. Morning stiffness. Morning stiffness, because they are not moving the joint. That's why. These people, movement of the joint help them rather than keeping it at rest. So when they don't move the joint, it gets stiff. So that is why rheumatoid, they have morning stiffness. That is the classic one of them. And then this one, pain at rest or after movement. So they like to move it more because then it is not getting stiff. If they don't move, they have pain and it gets stiffer. So you have to be able to distinguish. In the next generation, they will give you both, and they'll give you answers on the right, and they will say select or apply, which apply to rheumatoid or osteoarthritis. Is in the current one, they will have you the same thing, and they say which of the following is consistent with rheumatoid. They will just give you one of them. So, and they will put the two together to see whether you can pick which one of them. It's the same thing. So that's the key information I've put over there that I want you to pay attention to be able to distinguish between them. Because the joint is going to get stiff, what do you think? They have decreased range of motion of the joint. It's going to get hot in the joint, right? It's going to get red, and it's going to have swelling there. Don't worry. Work up, same thing. Anything that can see the joint, and we talk about them, X-ray can see it, right? MRI can see it, right? But this is classic. Because it's autoimmune, you need to get rheumatoid factor. So this will be elevated. And when you see ANA, ANCA, anti-nucleophile antibodies, don't worry about it. It's any autoimmune disease, this is elevated. It's fine. And they will give you ESR. Yes, it may go up. And the CRP up. So those are things you will do, you will see. Based on what we've talked about, how would you teach this patient? Here, teaching, okay, teaching. Remember about the stiffness. So you teach them to have range of motion exercise in the morning. That's where they stiff, not in the afternoon. So when the joint is stiff, you got to allow blood flow. What allow blood flow? Heat. So heat pads. When they have pain, joint is painful, yeah, you put some cold pads on it or ice. So that's the difference between them. They too, they need to take rest, frequent rest. It's okay. We got to prevent this is the key, the most important about rheumatoid. When you're teaching them, you want to avoid joint stiffness as much as possible. So when they go to bed, tell them to sleep on a bed that doesn't allow the body to change in shape. So like really flat, that flat in a neutral position. So hard mattress. It's not comfortable, but sorry. I mean, that's the only way we can prevent. So hard mattress. This will keep that whatever is the disease process, we want to keep it flat and in neutral position. So that's, you have to teach them that in order to avoid stiffness in the morning. Yeah. In order to do that, yeah, they have to sleep on a flat and neutral, be in the flat and a neutral position. And so they lay on a hard mattress. There's nothing wrong if they give you a mobility device. Even in osteoarthritis, you can use mobility device. I mean, things that will help them move around easily. And they too, they need a physical therapy. But these are the key: sleeping in a hard mattress, exercising range of motion in the morning, and taking care of the joints. And then which joints are involved and how you take care of it. That's rheumatoid arthritis. Treatment, very different from osteoarthritis. This, you remember, you have autoimmune. So if they give you answer choice, well, yeah, they will get the NSAID to help with that. But NSAID is not enough. They need some steroid. It's not enough. They need bigger guns. So methotrexate. These are medication for autoimmune disease. We call them immunosuppressants, okay, to decrease the immune system. And then when you see something called DMARDs, disease modifying anti-rheumatic drugs, and these include hydroxychloroquine. Okay, these are all going to lower. It doesn't prevent the problem. It doesn't let it go away, but it slow down the loss of function. Okay, hydroxychloroquine is one of them that you can. Plaquenil is also one of them. And then they also need immunomodulators. This is your pharmacology, like the MABs, okay, adalimumabs. All these things, the medication, they need it to affect the immune system. Because of that, we'll do pharmacology. I don't want to do it right here, but we'll do pharmacology. And when you see pharmacology question, you just already know, based on the name I've given you, you can tell that these people, we got to teach them a bunch of stuff. Okay, I got to teach you, because you're taking these big medication, you have to learn how to prevent infection, immunosuppression. So they have to avoid certain things, neutropenic precaution, all these things. So they can give you a question, rheumatoid patient on adalimumab. You got to teach them neutropenic precaution, don't eat fresh vegetables, or infection teaching that they need to have. You got to do that. Okay, so this is those two medications, those two problems, or no fracture. Then the last one is gouty arthritis. This one is easy one. It's due to like purine metabolism. They cannot break it down really well. So there's a primary one. That one is due to purine, okay? But the secondary one is you have hyperuricemia, and that can give you, so you have too much uric acid in your system. And that will give you gout. What are the risk factors? Well, family history is a role. Alcohol, bad. Okay, food that is as high in purine, yeah, you can use. That's organ meat and the rest. That's like organ meat. You can do that. Like yeast, sardine, classic, and spinach. Then obesity is another risk factor. Because it's an arthritis, yes, they're going to have pain, okay? Pain in joint. small joints. The bigger one is what? The big toe. Or the great toe, they will give you. If they give you a gout question and they don't mention the great toe, then it's not gout. It has to be that joint. The joint is the number one. Smaller joint, the great toe is number one. Your big toe on your feet, that's the one that is affected. And so they have pain and inflammation there. It hurt really bad. When you check, they do their risks of stone, so uric stone. And when you check their uric acid, it's greater than 7. That's the diagnosis of gout. So that's diagnosis. Because it's an inflammation, the ESR can go up, the CRP can go up. When you remove fluid from the joint, so synovial, we call it synovial fluid analysis, they will have crystals, uric crystals. That's how to diagnose it. Your treatment, you know it. Acute form, yeah, bed rest is better because they can't move their leg. And then you have to limit food high in protein and purine. Okay, and they have to hydrate themselves because otherwise they form kidney stone, usually uric acid kidney stone. Acute, they always will trap you. What medication you use? NSAID. And what NSAID? Colchicine. Chronic, yeah, chronic means I need to prevent. So prevent further attack. That's when you use allopurinol. So know the difference. It's not the acute phase is not the same as the chronic phase. So that's what is used for chronic. Acute phase, yeah, we need to manage the pain so that you can start mobilizing. But later on, I need to prevent you from having another attack. We put you on allopurinol. And then you have to educate them to avoid further attack. Okay, avoid the food. We talk about food high in purine. Okay, no E2H, sorry, and you got to lose weight. This is key. If they give you losing weight, don't choose anything that's a rapid. Rapid weight loss is not good. That will cause further attack. So slow weight loss because of the metabolism of protein. So slow weight loss as much as possible is what you need to have. So fracture is basically the bone is broken. Okay, it's just broken. There's a break in it. Okay, if there's a break, it's going to swell. Physical exams, next generation, they will give you that. Somebody for swelling, right now they can give you swelling, right? Skin color will change. They will have ecchymosis there. Something is broken. The bone will be deformed. Something is broken, right? What do you think? They're going to have pain. It's no normal. The muscle will be mad. Spasm of the muscle. I'm not memorizing, just giving you some of the, you will not be able to move it, loss of function. So when you see that, don't memorize it. You have crepitus. If you push on the leg, it will go in. You hear sound, cracking sound. Crepitus. Shortening of the limb. They will be limping. Yes. These are all signs and symptoms of a fracture. Something is not right there. The bone is not happy. There's difference. If you look at books, there's so many difference. I'm just going to classify them in 2 ways. Whether it's complete versus incomplete. And then whether it's open versus closed. I think that is the most important way of classifying bone fracture trauma. Complete means the bone, if this is the bone, there's a cut here. So you can see one end of the bone is like that. The other one is here. It's complete fracture. Incomplete, the bone is still in the posterior aspect, or one side is there, the other side is fractured. Right? This is incomplete. Open, closed, that means there is skin still attached to that. You don't see the bone. And open, this skin is broken. And one end is that. This is the only classification I'm going to give you. Drain stick, compound, comminuted, all this, I don't think is important. I mean, just know it just declared multiple. There's something that is broken. It's broken in multiple places. Yes, it's still broken. But these are the key that if it's closed, it's open, because that's where the management depends on. Okay. So that's that. The treatment is every time a bone is fractured, you got to immobilize it so that it can heal. It can prevent further injury to the bone. If it's open, you need to cover with steroid gauze. You need a steroid gauze on it. And you will need an antibiotic as soon as possible. When you are in the emergency room, where they get a tetanus shots, they get an antibiotic, pain management, and a muscle relaxant. That's the management of that. Treatment, well, we can splint it. That means we put in something, it does not matter, something that will keep the bone, the leg straight. So you can have any splint that will keep it straight so it doesn't move. It doesn't move. Okay. Or we can do something we call internal fixation. These are words you see. Internal fixation means we put in a rod through the bone. If this is one bone that is fractured, we put in another bone that is fractured. You put a rod there like that. And that stabilizes it. So that's internal fixation. When these are words you have to know. Open reduction, and I'll combine them together. Open reduction means you're reducing the fracture, but what are you doing? You make incision. So you open, you cut, you take the patient to surgery, and you cut the skin, and you get to the bone, and you put the bone in alignment, and you fix it. Open reduction. So sometimes they will combine these two. Open reduction, internal fixation. That means they take the patient to surgery, they cut the skin, they saw the bone, they reduce the bone, they align it together, and they put rod in them. That is open reduction, internal fixation. If we have open reduction, guess what? We have what? Closed reduction. That means they give you some pain medication. So closed reduction. They give you pain medication in the emergency room, and they twist your leg up and they straighten it. You hear a crap, and you scream once, and that's the end of it. And you put some splint and cast it. Excellent. So this is just to give you, in case you see some management, so that they give you some management, then you will know that, oh, this is what was done. Open reduction, internal fixation, closed reduction. Closed reduction, we just do it in the emergency room and then put some cast on it. There's a question, let me see. So allopurinol is not to manage gout. Yes, the allopurinol is for prevent, what is the chronic management? Is not, what I mean is you don't use it when somebody has acute gout. If you have acute flare-up, allopurinol, you don't give it to them. When the flare up has finished and everything, and they need maintenance to prevent further attack, which is the same as management. But that management, you got to define it. That management is after the acute problem, chronic management of gout. Yes, that's what you use allopurinol. But when the acute phase, they come out with flare, their great toe is red, you don't use allopurinol. Okay. Okay, I think that's that. So I guess some imaging for you, just a quick, that sometimes the fracture, we cannot fix it right away. So we just need to stabilize it for some time before we try to fix it. So you have these external fixators available. I use pictures so that you can see them in case you see them in the question. So these are, we call them external fixation. Then they can be skeletal, okay? They can have skeletal versus skin. There's different. If I'm putting in traction and I'm just holding on to your skin, using your skin to pull the thing in traction, that is a skin traction. When I have to go into your bone and drill to keep you in alignment, yeah, that is skeletal traction. This one is one of them. X-fix. This is external fixator. You can see that the rod is going through the bone itself and stabilizing it. This one, there's nothing going through the bone. This is what we call the back traction. So back traction is a form of skin traction without involvement of the bone, but it's doing the job that you need to do. Okay, so that's another form of traction, but it's an external, it's outside the body, and it's doing a marvelous job keeping everything in alignment that they need to be. So this is back traction. This, some people will call it skin, some people will call it skeletal. But I call it skin because this doesn't go through, they don't drill it into your head. So there's no bone, you know, but so this is skin, this is halo, okay? This is for cervical spine alignment. Okay, so but these are kind of traction you see, and you have to know the function of it. So we'll talk about each of them quickly. Traction, as you can see, it look bulky, it look like scary, but it's easy. You have to know how it's function. And they use it for your hip. When you have a hip fracture and want to keep it in alignment, yeah, this is what we can use. And this reduces pain and spasm. That is why we do it, to take away the pain and spasm from the joint. And the traction is below, remember, it's below the fracture, okay? Below the fracture site, you have to know it. This does not go through, you have a hip, but this doesn't go through all your hip. It's just pulling the lower leg and keeping everything in alignment. And there's a weight that is going to pull the leg, allow continuous. Nobody touch the weight, okay? The weight is what keep everything in alignment. Next, don't touch it, okay? Don't change it unless they tell you to add more weight. Yeah, let it be, okay? Don't manipulate it too much. The limb has to be in neutral position at all times. So that's the limb. You have to keep it in neutral position at all times. And it's very important. So for this patient, for every traction, you need to assess skin integrity. And you have to check neurovascular test. I mean, make sure the pulses is intact, everything is okay. And pain, when you start having bad pain, yeah, priority. Pain is your priority. in this situation. Number one, you got to assess what kind of pain. Is the pain going to let them lose the developing compartment syndrome? Yeah, you have to pay attention. And no side-to-side movement. They can have what we call trapeze. Trapeze is something they can hold on over the bed, and they can move their body, but the leg remain in neutral position. You cannot push them left and right. No. These are stuff you have to know about back traction. Okay. They can move, but they got to move up and down, not left and right. This is the halo, like I said, for cervical issue. And you can see, you also have to know how to take care of these patients. They stabilizing cervical and thoracic. The pins are the most important. You see, this one, there's no pins. This one, there's pins, okay? So the pins are the most important. You got to teach them how to take care of it. You can clean it. That's why some people think this is a skeletal. The pins sometimes can go into your head a little bit, screw, but it's not all the way to the bone. But like you said, I don't think they will ask you detail whether it's a skeletal or you just have to know how to take care of it. So the pin is where you have to take care of it. The key is just sterile water. If you don't have it, you can use chlorhexidine. It's okay. No hydrogen peroxide or anything like that. This is what you use for the pins. The vest need to be dry and clean. Very important. People will do so many fancy stuff in it. If you have to, it's wet, you have to take care of it. Yeah, use a cool blower to help with that. Don't use a hot one, otherwise you burn yourself. And they need to have foam inserts under pressure point so that they don't cause pressure injury. If they are in bed, small pillow is okay. Some people are afraid to do that. It take away the spasm from their neck, but you are not changing any alignment. If they're laying in bed, you can put a small pillow under the head when they supine, okay, under the leg the head when they are supine only. The screw and the pins, nobody touch it except MD. You, the nurse, what do? Have a wrench, whatever, how do you spell it? Wrench at bedside for the doctor to use it, or provide one for the patient, bring it to clinic every time, but they cannot change it. And when you're turning the patient, don't grab the frame, okay? Don't grab this frame, the device frame, don't grab it. You can grab the body here, but this is out of reach. It's easy to say, I'm turning them, so I'll turn the frame. You're turning their neck, you're causing more fracture. So when you're turning them from on the bed, use their body. Okay, so far almost cleaning up this one. And then the X-fix, you can see that one go through the bone. It's a skeletal traction. And so the same thing. It's a pin, you got to take, the question is going to be pin care for this as much as possible and how they need to take care of it. You have to look at it for infection daily. Very important. If you see a fever, drainage, and redness, pain, swelling, well, call me. Don't ignore it. We get osteomyelitis. That's complication. We don't want that. They can develop osteomyelitis from that. That's bad bone infection. We want to prevent that. Okay. Pressure point has to be protected. and they need to do strengthening exercise because you can't move the leg. They need to do strengthening exercise to keep the muscle strong. Okay, of the uninjured. Okay, that's very important. If I've secured one of your leg, if you don't do exercise, one of your leg will get weaker. So you need to work on it. So those are the key things about this. I mean, it's just straightforward. Okay, like I said, I'll give you facts that you need to know. They will ask you about pain management, what you need to look for, what you need to do. But exercise is good for them. And then cast is another form, but it's also a stabilizer. Okay, I don't know if yeah. So I'll put it here. Cast is also a stabilizer, but it's outside. It's a rigid immobilizer fraction. Okay, they can be a plaster. This is what happens when you do closed reduction. So we give you pain medication, we reduce the fracture in the emergency room, and then we cast it to stabilize it so that because we think you don't need any more surgery. There's two types. There's a plaster that they use versus fiberglass. They like asking this question even in medical boards. You have to know the difference. I'll give you one. If it's not the other one, then that's it. Sometimes when we give you too many information about certain things, you can get confused. I'll give you the fiberglass, fiberglass. So it's fiberglass. This one is really, really light. That's why people like it. It's lighter. Okay, it's stronger. It's stronger, even though it's lighter. It's water resistant. It's porous, so air can go in. You don't have to attempt to put something under it. Okay. Less skin issue. Does not soften when wet. That's why it's good. Therefore, you can use hydrotherapy while you have this on. This is why this is so important. Guess what? It's expensive. So in third world country, they can afford that. So good luck. You get a hard plaster and you carry it the rest of your days. But this is the opposite of this is what the plaster does. The plaster is heavy. It's just like you hate it, you know. It just is not feasible. But fiberglass is perfect, good. Kids can go to school without any problem. You can even cover it; nobody will know you pen it in. So it's very good. What do you do? Guess what? They will not leave you out of there. This musculoskeletal, they can ask you so many questions, Immediately within 48 hours, within 48 hours, there's certain things you got to teach them. Okay, don't cover it, let it be. So as the air dry, okay. If you want to handle it, you handle the palm, not the cast, okay. Handle with the palm. And don't rest it on hard surface. Otherwise, you change the shape. You have to elevate it to avoid edema above the heart. And this is very important. And that's what they ask you, be sharp. You're looking for pain, polar, peculothermic. Okay, paresthesia, paralysis. You know what I'm doing. That's the CSPs that you have to know about compartment syndrome. Okay, they're not going to have this. Okay, that's why when they have the early signs is paresthesia, like some weird pain, they can't figure it out. Yeah, you got to do something. Number one, okay, you have to go see them. And the patient who have cast, they will give you somebody have cast. You give them pain medication, it's not resolving. Be sharp moment. I have to see you. You have to see that patient. Paresthesia, you have to see them. If you wait until they have pulselessness, then the hand is dead. If you wait until they have no temperature, the hand is dead. It changed color, the hand is dead. So start from the beginning. Okay, they will tell you somebody have placed. They give you pain medication every hour. Is asking for main pain medication. Yes, you have to see that patient. That's a clue telling you they're developing compartment syndrome. So 48 hours is your key. Okay. After that, intermediate care. I call it intermediate care. This is later. They can also ask you, how do you take care of it? This one, the cast is dry, so they need to now exercise, so isometric exercise to prevent muscle atrophy. They should report any break in the cast. And of course, he's going to itch, but don't scratch it. Please don't do that. You have to tell them, don't scratch under. It's going to itch, but that's why Fiberglass is better. Cast is the worst. If you get wet, especially Fiberglass, this one you can dry it. It's easy. Cast is painful. You got to let the doctor know. It's hard to dry back again. So, but these are the things you have to know how to take care of it. After that, teaching you provide them. Any question? Let me see. There's no question. Okay.
What about infection?
So it's hard to get infection under the cast unless you. That's why you tell them not to scratch it under, because if the skin break, you won't see it and they get infection under. But hardly do you get infection from just the cast itself. Um, we, like I said, that's why you don't want them to break the skin under, because you can't see anything under the cast. You get more infection with the external fixators, like X-Fix and all those things. But this one, um, you got to just check pulses to make sure there's no compartment syndrome. Okay, so this is everything. There's a bunch of skeletal and skin traction. They just have names, okay, but they have the same idea, or they just the same idea. So when he asks you a question you never heard of before, see if you think about it, if it's a skeletal traction or is a skin, and you use the same thing with all of them. Make sure the weight, if it's a skin, make sure the weight is in alignment. Nobody touch you don't rotate it. It's the same thing. Most of the skeletal, the one go through in the bone, yeah, infection is the key. Same care. Well, we can't do this without not talking about the osteos. They are the osteos family. I mean, they 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 just who they are, and they are the same. They sound the same. Um, you just have to key words you got to use to distinguish between them. All of them is bone lost. There's two. I don't want to go into detail too much. It's unnecessary. There's two cells. Okay, there's the clast, osteoclast. Okay, and there's the osteoblast. Okay, class basically try to chew the bone, and the blast usually make bone. Somebody's making bone, also, and somebody break it down. Those that break it down causes the bone density to go down. So you want more blast to do its function than the class to do its job. And osteoporosis, the class is taking over. So you're losing bone. Usually you're absorbing bone that is being made. Okay, so there's a decrease bone density. And you know how to test bone density. We talk about it, DEXA Scan. The risk increases when you are more than 65 for women. Okay. After 65, you start losing your bone. Steroid causes bone to break down. Okay. Estrogen, when you get more, you pass the age of 45, yeah, your hormones goes down and your bone start losing it. Protein deficiency, yeah, another. And smoking, yeah, that's right. You don't have to smoke. Yes, this is very important. We all have to go to the gym. Sedentary life. When you exercise before you get to 45, your bone is strong and they are not brutal. After that, they get weaker. You know, they lose all they are not strong. So you got to exercise. So sedentary life is not good. How would you see these people when they have osteoporosis? They're very short. All of a sudden, they're 6 feet. Now they're 5'5". Your mommy taller than you, all of a sudden you can see that now you're tall. Yeah, that's a sign that their height is shortening. Something is not right. They've lost some height. And then there are fractures, pathological fractures. So that's some of the features you see. And then you see that they are born, they start developing kyphosis. When you do a DEXA scan, yeah, it's decreased. Bone density has gone down. So those are the features you see in osteoporosis. For you, your job is to prevent this nursing care. So let them do weight-bearing exercise. It's good for them. Strengthening exercise. Of course, eat some calcium and vitamin D. The clue is, I need to tell you that sometimes they confuse you. If your calcium is low, vitamin D will help. Vitamin D help with absorption of calcium. But calcium does not help with vitamin D. So pay attention because they can trap you. Somebody with vitamin D deficiency, calcium is irrelevant because it does not help with that. But if your calcium is low, yeah, we can help with that by giving you the vitamin D, which help with the reabsorption of that. That's the difference. And then I think the most important with all this problem is you want them to avoid injury. So first, stop smoking, but then for precaution, okay, you don't want them to fall. If they come to the hospital, yeah, you have to ensure they don't fall. And then we got to help them build their bone. So medication, I'll talk about farm. Hopefully we have time. You got to help you. If you see this bisphosphonate, don't forget, every time you hear about bone problem, you got to choose this answer, okay? Bisphosphonate. They are allodonates. It's a class of medications that usually help you to like build your bone. And it's very, very, very important. And everybody who has bone issues should have one, at least, to stop the effect of bone loss. It's very, very important medication. And so you have to like get a patient to get it so that they can get a replacement. Okay. They are the bisphosphonate. And the easy way to recognize them I call them the dronate. Example is, I think the common one is Arthroscopy. Yeah, these are the dronates. They help with the bone and build up. You have to give them calcium too. You got to give them vitamin D. If they need estrogen, we give it to them. But you got to watch estrogen. The side effect is the uterus. They will have uterine bleeding. You have to check it. If the lady is postmenopausal, I have to say it. This is clinical. You may not pay attention to that. I give you estrogen where you go to your uterus, it binds to the muscle and the mucosa, and you start bleeding. Postmenopausal bleeding is a problem. Uterine cancer. So we got to pay attention. So if I give you to this, it will stimulate your uterus, start bleeding again. Now you're 60, you're having your menses. It's not good. And so we got to watch it to make sure you're not developing cancer from the side effect. So pay attention to that. And this one, most people don't know that this is calcitonin. Also stabilize. It block osteoclast from breaking down the bone. Okay. And then you can give them PTH. A PTH form is teriparatine. Those are the medication that, like a PTH, that will improve their calcium function, and then that will help with the build up. So every time you see a question, I just give you all of them. And somebody calcium is having like issue with the calcium metabolism, and they have problem with the osteoporosis. Yeah, bisphosphonates will prevent breakdown. Calcitonin also will break down. You give them calcium and vitamin D to help mineralization, and so this is what they need. Let me see if there's a question. Who have higher risks between male and female? So female has higher risks. So female have more osteoporosis than male. Okay. The next one is the Osteomalacia. And as you can see the name, this is like bone destruction. It's irreversible. No, it's reversible bone and disease that you can reverse the effect easily. And it's due to vitamin D deficiency. That's why I emphasize osteomalacia is reversible, and it's due to vitamin D. But remember, vitamin D is involved in help with calcium absorption and phosphate. Every time you have vitamin D deficiency, that means you're lacking calcium and phosphate. These cannot be absorbed from your GI tract, so we need it. So these people are weak, they have soft and painful bone. You see, the different from the signs and symptoms I give you: weak and soft bone and painful. The bone is so soft and weak. They can fall easily at risk. That's for precaution. So you got to pay attention to that. So your intervention, the nurse, is safety for this patient. The weak bones. They get cane, they get walker, whatever they need, so that they don't have to fall. Despite that, they got to do exercise, so light exercise, not a moderate one, but something light that will help with the issue. Okay, they too can do exercise to improve their function. It's very important. So what do they need? Give it to them, right? In medicine, if you need something, we give it to you. They need calcium, right? They need vitamin D, phosphorus. So what are we going to do? Increase something that has calcium, green leafy vegetables is very good. And some dairy products. And then the vitamin D, they go to the sun, they bathe in the sun, that's good, right? And then the phosphorus, mostly organ meats. Some fish, some poultry will be fine for them, whole grains. And that will help with their situation. But that's different from osteoporosis. The other one is myelitis. You see, osteomyelitis. He has hiatus, so it's infection, right? It's an infection. This can be acute or chronic issue. Who is at risk? Think. IV drug uses. If you inject, well, you inject into the bone one day with infection, so we get into trouble. Trauma, yeah, they have bad trauma. And diabetes patients, yeah, we have high rates of osteomyelitis. So we got to, that's important, something that you pay attention for them. What do you think signs and symptoms, both next generation and now? Well, you're going to have fever. You're going to have bone pain. Okay, there will be redness there. There will be swelling there. You have chills. You'll be sweating, diaphoretic. Your heart rate can go up. Your white count can go up. Everything that you think will happen. If you get an ESR, it's up. CRP is up. Right. How do you diagnose it? We talk about a treatment to diagnosis. Get a bone scan. Everything will light up. Okay, you can get an X-ray. It will show gas, infection sign. What is the management? Treatment, they need an antibiotic. It's key. They can have long-time antibiotic, long-term. So this patient may have like a peak line for management. It can take a while. Key fact, listen, key fact. If there's a wound draining from osteomyelitis, put them under contact precaution, because they may have some MRSA involved. So you go to MRSA, they may have this organism. So if there's no wound, it's not draining anything, yeah, just infection, yeah. But if you see like the drainage, obvious drainage, fluid coming out from that thing, yeah, contact precaution. And you have to teach people to take full course of antibiotic. Otherwise, you get him. If they have recurrent infection, you can't treat it anymore. This is a bad disease. Let's look at this Paget. It's also the same thing. But the key, the buzzword for these people, I may have one, I don't know, bow-legged, okay? Their leg is bowed, like, yeah, like, I don't know how to describe it. It's like that, But the leg is weak. My leg is not weak. But their bone is long bone in the spine. Yeah, they have pain in the spine and the rib. They hate it. They have brutal bones, Their height too, these people, their height is also decreased. But when you give you X-ray, your skull is enlarged. These are key. And when you get an X-ray, you see a bunch of pathological fracture. It's like Paget disease. It's classic. And it's due to bone reabsorption. All of them excessive bone reabsorption. Bone is being taken away. What will be your treatment? Yeah, take some rest. Okay, fall precaution. Same thing. We don't want you to fall. Okay, manage your pain. And safety is the key. If they need a assisted device, give it to them. Don't be mean. And encourage some rest. Once again, medication is always the same. I need to prevent bone breakdown, so calcitonin and then bisphosphonates, like I said. If you know it is going to be the same, it's not going to change. Just keep on using the same theme. Any question? So those are the difference between all of them. Porosis, Malacia, Myelitis, and Paget. Bone diseases. Now let's do the plastics. You can see we said arthroscopy, the same thing, the same idea. Arthroscopy. And we said this is joint and this is looking inside. Well, we change it, arthroplasty. So what does that mean? The same thing. We joint, every time we say plasty, we're trying to patch it. You're patching something. So you're redesigning it. So basically, new joint. It can be knee or hip replacement. That's what it means. So when you say it's a hip, some patient had a hip arthroplasty, it's different from scope, arthroscopy. So your management, remember the things we said, scopy is going to be different. This one, plastic, we're fixing it, we're placing a new joint there. So that is different. Okay, that is different. And the indication, probably they have trauma there, that the knee is broken, or they have osteoarthritis or rheumatoid that it can't do anything there, or they have cancer, they remove the joint, so we got to replace it. What they like to ask you is after surgery. So hip replacement, post-op. What do you do? The key for you is to keep the legs away from each other. So keep the abductor. The word is abductor, not adductor. Adductor means I'm adding it together. I'm bringing the knees, the hips together, or the legs together. I want to make them away from me as much as possible. And so what do? You put adductor wedge. So if this is one leg here, we take a wedge and put it in the middle. I put a wedge here and keep the two legs away from you. So the answer choice is abductor wedge. So you place an abductor wedge in between and then they use it. So abductor. Okay. They should do not flex. I don't want to flex more than 90 degrees. 60 is the maximum, even though you said I want them to go up to 60 degrees. If you want to flex the hip, but don't do that. And you should not position them on the operative side. So if the operative is on the right, yeah, you cannot let them lay on the right. No. Okay, very, very important. And then what do? Your assessment, You the nurse care. You have to assess for pain. They are pain, whether there is rotation of the hip, and then if there's shortening. If there's shortening, that means there's displacement, dislocation. You do a neurovascular check, and the wound is aseptic technique to make sure it doesn't not get infected. This is the key. They will trap you. They have to walk before they leave the hospital. Most of them are in the hospital 1 to 2 days. So you have to walk. Otherwise, you don't go home. And some of them, they walk in the park you right away. So if they give you a question and patient is going on with the walker, yeah, don't choose it. It's a trap. You should not go home with the walker. You should be walking. Otherwise, we're not letting you go home. So please walk. And then you teach them how to prevent DVT. How do you do that? Don't cross your leg, okay? Right? Your feet, you got to put it in circle. When you're sitting down, move your feet in circle, like you're drawing something with your feet. And your feet can go up and down, so dorsiflexion. Or will prevent that. And then they should be doing that to prevent DVT as much as possible, and push on something to help with the isometric exercise and the quads. They can do straight leg exercise. So it's also okay. These people may go home with NSAID. Don't, it's okay when you see anticoagulation, Coumadin or Lovenox. I know we don't combine them with that, but this is a typical situation where we don't want them to get DVT. Bleeding is okay, we can fix it. That they may be on NSAID and they will still have Coumadin and Lovenox. So don't worry. They may have opioid and an antibiotic as needed. But it's very important that you teach them all the things, abductor, and the things they should do not to cause problem. You should not turn them on that side either. Okay, so abductor web, you should avoid what? Adduction and flexion. I got to say it again. Adduction and flexion. That's the key. Flexion of the hip and adduction, bringing the two legs together. We want it to be abducted away from each other. Or is this a question? Yeah, you can use pillow. If you don't have it, use the pillow. It's fine. Okay, so that's that. Then there's a knee. The same thing, knee replacement. For the knee replacement, we want to avoid contraction, okay? As much as possible. So we want to keep the knee in extended position as much as possible. And don't put anything under the knee, no pillow, anything like that. So that is key for that one, okay? Some people think this is wrong, but that is the only thing, because the only way we can immobilize the knee is very important so that it can still function well. So they use a knee immobilizer. Everybody who have the knee, they will still work, but they have a knee immobilizer in place to keep in alignment. So they will use it. So no pillow under the knee, but you can put it under the heel, okay? The heel or lower leg. Heel or lower leg is okay, but not under the knee. So pillow. That will causes the contraction. So we don't want that, but you can pull it under the heel or the lower leg. So if you see these words CPM, you have to check. Don't freak out about it. It's basically continuous passive. It's just doing something for them. Continuous passive motion device we put them on. And also improve their flexibility. Anybody who have a knee replacement will have this. Once again, this one, 3 to 4 days, they can bear full weight. They stay longer in the hospital. So they should be moving still. If they tell you 5 days they are in a walker, something is wrong. I want you to move. So 3 to 4 days in 72 hours, they should be moving. Okay, amputation. There's different kind of amputation. So let me draw it. So if this is the leg, I'm not good at. This is the knee, okay? The hip is here. So anything here is below knee, so we call it BKA. Anything above the knee is AKA, above knee amputation. That's all. So when you see it, that's what it means. Above knee amputation, below knee amputation. They have different features, but still they have the same thing. All the difference between them is function. Remember, if it's below knee, you're much better off. If you above knee, your function is decreased. So people who are below knee do much better than above knee. Okay. The priority function, who do you see? Is to prevent flexion contraction, like the knee I told you. This is key. How do you do that? If you cause flexion contraction, then the amputation is not going to be effective anymore. So what? They should not do. I want you to pay attention. If they're going to ask you the question, this is what they will say. Don't elevate it after 24 hours. But before 24 hours, so I'll clean it. Elevate it, the amputation, first 24 hours. After 24 hours, don't elevate it anymore. Then what? You put them in the prone position. Prone position, 30 minutes, 3 or 4 times a day. Key fact. Don't elevate it more than 24 hours. Then now prone position, 3 to 4 times a day. Then you have to wrap the amputation with a bandage. So compression bandage over the limb for 24 hours. Then after that, you can loosen it. You can loosen it slowly. So that is the first 24 hours. These are the key facts. They should not sit more than an hour. So avoid sitting greater than an hour. This is all will prevent contraction. The limb need to be clean, okay? Just soap and water is fine. Soap and water only. Don't use any special cream or anything, and then you dry it. No alcohol, no powder, nothing. Soap, water, that's all, only. You got to check for infection. And then there's something we call socks. They put the socks around it to put the compression around the prosthesis so that it can dry up and everything. So you put the socks on to tighten it. It take away all the edema. And they should be doing range of motion exercise. So range of motion exercise. There is kind of pain that they may have. This, they can also ask you pain for these people. There's different pain. If they have residual limb pain, they feel like the limb is there. This one, opioid is the best medication. It's different from phantom. They thinking about it that the limb is there. Okay, that one you give them calcitonin. If they're having spasm, yeah, you give them antispasmodic. So you got to figure out what pain they have it. If they tell you it's a burning pain, okay, and it's constant, it does not go anywhere, this one, beta blocker, is the best way. It has autonomic aspect of it. But if the same burning pain, it feel like knife-like. Yeah, this one is, you got to use anti-epileptic, like seizure medication will help. So that's the kind of pain they will have. They will have like knife-like pain. They may have burning pain that is constant. They will have spasmic pain. They may have phantom pain, limb pain. It's all different. Which do we elevate below the knee, above them? All of them, you have to elevate it the first 24 hours. If they can, the elevation means they put a pillow under to be up instead of being flat. So all of them, they get a pillow under it.